So now I invite Dr. Jaffe and Dr. Chappell. And I guess the concept that we are going to discuss is that when you are seeing a patient and evaluating a patient, do you discuss with them the latest trial that have been published in the medical literature, and do you try to have them make an informed consent based on evidence-based medicine? So the question that I have is that, Dr. Chappell, how do you explain to your patient this whole issue of evidence-based medicine and decision-making for them?
Well, I think that the most important statistic that I stress are the number needed to treat, well, and along with that, the number needed to harm. And I tell them when they go to their cardiologist, those are the questions to ask. With whatever intervention they're talking about, what is the number needed to treat, and what is the number needed to harm? Depending on the studies, for statin drugs, for example, the number needed to save one heart attack in primary prevention is somewhere between 100 and 200 patients. So that means that 99 to 199 are going to receive no benefit.
1 in 200 patients for statins and 1 in 163 patients for aspirin.
Yeah. Yes. Aspirin's very similar. So I think that it's pretty hard to argue with that evidence because it's out there. And that's what I usually ask them to do, just to ask that, so that the cardiologist will at least be open to listening, that the patient knows something of what they're getting into.
Mm-hmm. Dr. Jaffe?
Well, first, for full disclosure, I am principally a laboratory and research physician. I have had a closed private practice, very small, for many years. And I learned from Al Augustin many years ago that an informed consent, and today I would say that not just a written but a video informed consent, is absolutely essential if you want clarity about not only what you said, but more importantly what the patient heard. Because if you ever get into a question, the question will be, what did the patient believe, or what did the patient understand, or what did the patient think? I find it very helpful to have an extremely detailed informed consent that gives them much opportunity to read, or just accept. You know how you click today to accept things on the web? Further, I ask what questions they have. I don't address questions that they don't have, except in a very global way, because my experience is that even the most attentive patient remembers very little of the content of what we say. They remember the style, they remember our confidence, they remember the look in our eye, they remember their feel. But if you actually ask them, even 15 minutes after they walk out of your or my office, it is often very hard for patients to remember the particulars. That's part of why I also have a staff person. And the staff person meets them after they have talked with me and asks them if they have any questions, and if they don't, ask them, what did I say? And do you know that what the patient thinks I said might be different than what I thought I said? And my staff generally knows that difference and says, well, I understand what you said, but here's what Dr. Jaffe meant. We would never say that I made the mistake, of course, but here's what Dr. Jaffe meant. So that before they get out of the office, they have the opportunity with a staff person who is compassionate and caring to review what they thought happened, if they have any questions, and if there are things we want to reinforce, we reinforce that. Today, we actually give them a flash drive, if they want that, so they can have a written or a virtual version, and they can then take that home, and if they have any questions about it, they can let us know. So I do address the questions as they have them. I don't presume that because I have the information or I want them to know about it that they're at all interested or will retain it. And since I believe they're only going to retain a little bit, I concentrate on that.
So Dr. Chappell, going into the benefit of medical therapy over intervention, so what's your opinion of the two trials that have clearly put into question the use of invasive procedures in cardiology, the OAT trial and the COURAGE trial. Can you give us your brief opinion?
Well, it's pretty dramatic, actually. The OAT trial was after a certain type of heart attack, and the whole idea was that if you used angioplasty to open the artery after you have a heart attack, that it would improve the outcome. And it showed just the opposite, that medical therapy was a little better than angioplasty and stents. And then the COURAGE trial was more as a primary prevention tool, and that involved like 85% of the angioplasties and stents that are done in this country, and it was shown that they had no benefit over medical therapy. So the comment in the article, and there is, I put a copy of that in the syllabus, was that some professions seem to have very little in the way of evidence to back up their whole specialty, you know. And I thought that was a pretty strong statement to come out of the Journal of American Medical Association.
They said
the opinion of the experts.
Yes.
Right? They have the opinion of the experts, and that's
Right.
About the cardiac procedure. Once there was a professor, I was attending a seminar, professor of cardiology, addressing how massively treats heart disease and blood pressure and on, and how fast he goes in putting stents and stuff like that. So I asked him one question, you see, when you put the stents in there and that improves the outcome so much, then do you think their life insurance should go down, the risk goes down? He said, no, it actually increases. So I said to my staff, if you send the patient to the slaughterhouse and patient comes out with increased risk.
So in that sense, should we be discussing statistic with our patients when we do it informed consent, or should we just have that information for ourselves? Not necessarily the COURAGE or the OAT trial, but some other trials that discuss the trivial benefit of some cardiovascular intervention. How do you approach your patient? Like in your informed consent, do you say, is there a line that says, I have discussed with them the evidence of this and this trial? Or
Right. Yes, I certainly discuss the evidence of that. Of course, the problem is most people that are faced with the decision on whether to have a stent or not, they're in some kind of hospital situation or a critical situation or supposedly critical situation, and the patient is in a very much a position of low power, and they have to make the decision on the spot. So I tend to talk about these things in general with patients before that happens, you know, when we're talking about risks.
We're going to die immediately.
Yeah, that's right.
Dr. Mason?
I do not talk about statistics with people. I do talk about conclusions. I explain that if you start from a fatally flawed misassumption, or if you start from the wrong place, you will likely end up in a further wrong place. And the wrong here is you, the person, are not a machine. The plumbing analogy that is the basis for even those recent trials we're talking about was disproven in the 70s, but as research goes, it takes decades after the disproving to get the concept out of the people who design the trials, which are often long-term trials. So I do explain to patients the results. I do explain to them my understanding. I ask if they understand my understanding, and I don't talk about statistics.
Thank you. So we are going to have, oh, sorry.
Can you share your consent form with us so that we know what exactly what's about?
I'd be happy to share mine, but mine is by accretion, which means all I did was add a whole bunch of things to it. I don't think I have the state-of-the-art informed consent. But if folks are interested in the state-of-the-art informed consent, I would actually start with the NIH one. If you look at NIH's informed consent, you could modify that, or other folks here may have better aesthetics in their informed consent.
Can I make a comment on informed consent? We had a discussion at the ICIM board meeting last night that we're going to be compiling a variety of different consents and putting them on the member side of the ICM website.
Oh, bravo.
available to everyone who's an ICIM
Thank you, Robin.
member.
That's terrific.
I'd just like to make a quick comment about something that was actually published in Wall Street Journal, quoting a medical journal, I can't remember. 17% of stents on a review by an independent body were totally unnecessary. 37% were questionably necessary. So almost
That's only
50% weren't necessary. The medical treatment would have been fine. The other thing is, I so much agree with you, Dr. Jaffe, about the statistics. It has no role in human medicine. I took a course in biostatistics as an undergrad, and I took another course as a graduate student in the philosophy and foundation of science. And I almost flunked the course because I got in so many arguments with the professor about the fact that human beings cannot be statistically analyzed.
Well, thank you.
The student t-test, the Wilcoxon chi-square, all that stuff you can apply to the length of a rat tail or the weight of a mouse kidney just doesn't work in human medicine. That's what I got taught in terms of statistics. In medical school, we get nothing. And then all of a sudden, we're talking about absolute risk, relative risk. And they're telling the patients on TV there's a 37% reduction in cardiovascular events in patients that take this statin drug, when it really boils down to that is a relative risk value. It doesn't mean 37 people out of 100 don't have a heart attack. And that's what the patient comes in believing. So you have to explain the nuances of how they've used statistics to form lies. I got a little book from 1954. It says How to Lie with Statistics, and they found a really great way in the pharmaceutical industry.
Thank you.
There's a good book that explains that in detail called Statistics.con.
Just my 2 cents as far as the consent issue is concerned. What I'm fighting with my Louisiana State Board right now, and Jim Carter knows my plight right now, but check your states and find out what they say your consent needs to say. My consent prior to all my stuff did not say that I went to medical school. Now it does.
Bravo.
One further observation on statistics. They assume that everyone is interchangeable. Post-genome project, especially if you're doing pharmaceutical research, you don't know what the cytochromes are in the probands and controls, you don't have useful data. You got anecdote, which is about 95% of the literature.
Thank you.